This is Brent of the Brookbush Institute, and in this video we're going to go over manipulations or high velocity thrust techniques. I assume that if you're watching this video, you're watching it for educational purposes and that you are a licensed professional with high velocity thrust or manipulation techniques in your scope of practice. If you're not sure, check with your state board. Most physical therapists, chiropractors, and osteopaths, you're in the clear. I believe that ATCs, you can't do manipulations in the United States, although other countries. Again, check your scope. Of course, massage therapists and personal trainers, these are generally not within your scope. Of course, you could continue to watch these videos just for educational purposes, learn a little anatomy, learn a little biomechanics. If you're going to do these techniques, please make sure that you have a good rationale for putting your hands on a patient. This should be based on assessment, and if you're going to assess, I'm hoping that you'll assess, use these interventions, and reassess to ensure that you're getting the result that you're looking for and have good reason to continue using this technique. In this video, we're going to go over the cervicothoracic junction manipulation or upper thoracic manipulation, that area between C6 and we'll say T4. I'm going to have my friend Yvette come out. She's going to help me demonstrate. Now keep in mind, if you're doing manipulation techniques, you're doing them to increase mobility, not just based on subjective symptoms, but also based on objective signs. So in this case, I would probably use something like cervical lateral flexion. Cervical lateral flexion goniometry is reliable, although some of our other cervical goniometry assessments are not so reliable. And then I might try to find a thoracic rotation test that works well for reassessment. The last thing I would rely on is palpation. Now, I generally do two types of palpation with this particular area. I'll do my PAs like I do when I'm doing mobilizations, and then I'll do this rotation palpation that I learned from the Maitland workshops. So the PAs here, you're going to go thumb over thumb, or you can go your piezoform hamate grip, whichever you find more comfortable. Generally, I find that I'm in this position when I'm working with neck and upper back patients like this. So to go thumb over thumb is a little bit more convenient. And I'm just going to press all the way down to arthrokinematic end range and kind of feel how these segments feel compared to one another and compared to that internal model that I've built up over time with experience pressing on a lot of necks and upper thoracic spines. And I'm going to try to give myself a little bit of an indication of how stiff this area feels. Of course, we could add another layer of this and go, hey Yvette, how does that feel?
That's fine.
Okay, so that feels fine. That feels fine. We might get a little additional information, like what if one of these segments is not only stiff, it's actually part of the dysfunction that's causing her symptoms or complaints. And I can kind of go on through and do these PAs. Now, what I'm feeling with Yvette is she definitely feels pretty good in her cervical spine as far as motion goes. But then as I start moving down C6, C7, C7, T1, and then like C7 to T3, it's like really stiff. It's actually really hard to get arthrokinematic motion. I don't think that's normal. I think that's an abnormal level of stiffness that maybe indicates I should do this manipulation technique. Now, before I do this manipulation technique, I've found that this rotation assessment that I learned from these workshops works really good in helping me determine which direction I should go. And all I'm going to do is I'm going to take my thumbs like so and put them each on a spinous process and rotate the spinous process in the opposite direction. All right, so we'll go this way and then this way. Right, so I went this way and then this way. I rotated the upper segment to her right and then to her left. And then the same thing going on down. And what you'll start to notice a lot of times is people get stiff in one direction. So in Yvette's case, she actually moves better rotating to her left. Now, I cannot explain what I'm about to tell you biomechanically, but it seems that this manipulation works better if rather than going into the resistance, trying to manipulate to get more range of motion or decrease stiffness in the direction you're feeling it, it actually works better to go with the motion they already have. We could make an excuse and say, well, technically speaking, if we're rotating in either direction, the fast sets on both sides have to move. So at the very least, we know if we get a good manipulation, everything's moving regardless. I really can't explain to you guys, though, why moving with the direction they already have motion tends to work better than moving them into the direction they have stiffness, like every other manipulation. Experiment with this yourself. I think you guys will find the same thing. One thing about this technique is it's better to be right the first time, because this is one of those techniques that if somebody is a little irritable, somebody is a little inflamed, flared up, you keep reaching back and trying to do the technique over and over again, and you'll flare them up more. This is one of those techniques that you might get 1, 2, maybe 3 attempts at the most before you need to back off for the day and wait for them to come back in. So in Yvette's case, I'm going to go ahead and I'm going to rotate her this way. She moves better in this direction, and like I said, that tends to work better for this manipulation. Now I said she's stiff in all these segments going down here. There's 2 ways to block segments, and there's an easy way to set up the joint actions that we need to lock up the upper part of her cervical spine, or the upper part of her thoracic spine as well. So what we're going to do is we can either use a thumb on a specific segment, or we can use our thenar eminence to block off several segments. This obviously is probably a little less specific and a little bit more aggressive. In Yvette's case, I'd probably start here, being that she's not somebody who's accustomed to getting a lot of manipulations. She hasn't come in to see me before. I probably want to start off a little bit more gentle and see how she responds. Now, in order to get her all locked up, I want to rotate her this way, side bend her towards me. So it's still that contralateral rotation, it's still the ipsilateral flexion, and we're still needing a little bit of extension to get in the lock position, just like we did with the cervical spine. The nice thing about this particular technique is if you just lift their head out of the head cradle and then kind of rock their head on their chin, just by turning their head, they do it automatically. All right, so you can see if I just kind of push her out of the head cradle, I'm there. Now I can tell, in this case, Yvette's guarding on me a little bit. One other thing I should probably bring up that this table does naturally, but some of you guys don't have tables with these arm thingies, is their arms need to be up. And the reason why is you want to take slack out of these muscles. If I was to try to rotate her this way with this arm down, you can see I'm adding a lot of tension into her upper trap, and that's not going to be helpful for getting a manipulation. So you can bring both arms up. If we didn't have these arms cut out, she could actually put her hands underneath her forehead like this, and we could just turn her forehead on her hands. It would still work the same way. All right, so you can put your arms down. All right, we're going to try not to guard. In the case of Yvette, if she is guarding and I feel like I keep getting pushed out of her spinous process and I can't hold it down with just my thumb, I might go back to my thenar eminence like this. All right, so now I can really make sure I stabilize. I just have to try to be a little bit more careful to line up the end of my thenar eminence with whatever segment I'm trying to lock out from the bottom down. All right, so in this case, I want her about there. I can then bring her this way. All right, you okay? No pain? Just relax, nice deep breath. Try to just pretend like you're laying on your pillow on your belly. All right, so I do find that that cue helps, guys, is like try to get them into like thinking about like relaxing on a pillow, okay? Now all we're gonna do for the manipulation is add a little pressure this way, right? So I'm moving this hand this way to block out, whether it's my thumb or my thenar eminence, and then I'm going to go this way with this hand, because if I do that, I automatically push her into lateral flexion and rotation. So it ends up being a very easy technique for us, as long as you spend plenty of time getting your setup right. You make sure you get a really good lockout. All right, get a nice deep breath. You okay? Deep breath, breathe out, and that's it. And we actually got a pretty good cavitation on that one. I know Yvette felt it. You guys, you're seeing these manipulations done on somebody who does not get manipulations done. All right, so I think that is important. That's a lot more realistic than some of the videos I see out there with people doing manipulations on people who get manipulations all the time. You do have to be careful. You do have to set somebody up well. You do have to help them with their expectations and be like, hey, this is not a big deal. It's going to be over really quick. And, you know, take a nice deep breath. And before you know it, click, and then you just let them go. And a lot of times after I do manipulations like this, I'll actually have somebody sit up, take a second before I go ahead and do my next technique so they don't feel like they're getting rapid fire, high intensity manipulation one over the other. All right, so I'm going to show you guys from this side. If I was going to manipulate her other side, I would just block this way. I would put her head on this side, and I'm not going to manipulate this way, okay? All right, so I would go ahead and put either her chin up on the table, or maybe like in this case on this head cradle, her maxilla is actually resting at the end of that headrest, right? And then I'd get her right here, and then I'd make sure I'm locked. If I need to change her head position, I can, right? I want to make sure everything's right. Again, guys, I've said this in every one of our manipulation videos. Setup is 90% of this. If you get somebody locked up right, if you've done your assessment and you're on the right segment, the manipulation, the high velocity thrust, is like the icing on the cake. In fact, I think you guys will find that if you really get good at the lock position, you'll get people to like move, manipulate, cavitate before you even get the thrust to happen a fair percentage of the time. It's kind of interesting. Like you'll just be like, okay, and you'll get them here and they'll be like, and you're like, oh, okay, I didn't even need to do the thrust. All right, so again, I could do my little rotation stuff, find the segment. In this case, I'm gonna go with the easier motion, block out that bottom segment, make sure that I apply a little pressure this way, and then wow, I'm gonna rotate the head this way, which is gonna push her into rotation and lateral flexion while I block out this way. Last thing, guys, and I don't wanna come across as sounding arrogant on this, but I think it's something that needs to be said. For whatever reason, because I own this education company and I'm available online, I get a lot of individuals who come and find me after other practitioners didn't work for them. And I would say 9 times out of 10, I'm able to help somebody because something was missed. That shouldn't happen. I think this is one of those things that is very often missed. I can't tell you how many cervical spine patients I've had that were manipped to death up here in their cervical spine. Nobody ever looked at their CT junction, and they were never given any sort of like activation or stabilization exercise. With these type of patients, a lot of times I can come in and I manip their cervicothoracic junction using this technique. I give them some deep cervical flexor activation, maybe some serratus anterior activation. Maybe we'll work on some other stuff for scapular mechanics, right? All that stuff that gets left behind because their last practitioner only looked at their cervical spine. And sure enough, within a couple sessions, they're on a home exercise program and they're good to self-manage. Guys, keep this technique. Although it's a little difficult, although it does have a little higher tendency to flare people up than some of the other techniques I've shown you, get good at it, because like I said, it will make you a lot of money, and it's making me more money than it should. Stay tuned for the close-up recap. All right, guys, for the close-up recap, remember we're gonna start with our subjective assessment, then objective assessments, and of course, the last assessment we're gonna do is our palpation to try to give us an indication of where and which way we should manip. And what you're seeing me do here is that thumb to thumb on spinous process PA, and I'm just going all the way to the end of arthrokinematic range, kind of trying to feel the relative stiffness joint to joint, and then of course my own internal model of stiffness at these joints based on my experience. To add another layer, we could of course ask a vet, hey, how does this feel? Sometimes what you'll get is the patient will complain about pain when you press on a particular segment, which might help us get a little bit more dialed in with our manipulation techniques or soft tissue techniques. Then the other thing I'm going to do, of course, is that rotation, right? So you guys can see I'm on either side of spine in this process, and then I'm just zip, zip, right? And then I'm going to switch my thumbs so that I rotate the other way. You guys kind of see how that works? I think with a little bit of practice, you guys will get pretty good at going all the way down the spine and starting to determine the direction here. And then, you know, we found that she moves, she gets stiffer as she goes down here. So we might want to block like so, or we can block with a thumb like so on that spinous process just below the segment that we think is stuck. And then we're moving with the direction that she moved better. I know that's very odd and doesn't make a lot of sense, but it does tend to work better based on assessment and outcomes. And then of course we're going to turn her head off the face hole here or the face cutout on this table, which is immediately going to put us into extension, rotation, and lateral flexion. And I'll spend a couple extra seconds trying to get a good lockout position, maybe a little bit more extension, maybe try a little bit more flexion, maybe try position a different part of her face. See if that helps. Try my thumb, try my thenar eminence, see which one gets the better lock. You do want to be quick in the sense that nobody likes to be in lockout position for long, but don't be in a hurry. Everything is set up. 90% of this is finding that lockout position, and then once you find it, all you have to do is one quick thrust and be done with it, right? So it's all set up. The thrust is just the icing on the top of the cake. If you guys have any questions on this whatsoever, please feel free to leave them in the comments box below. A couple of points to recap. Knowing your anatomy and knowing your biomechanics will certainly help you choose the right technique for the right patient. If you're unsure whether manipulations are appropriate due to their higher intensity, it's okay to do mobilizations. Most research points to manipulations being slightly more effective, but mobilizations being very effective. And of course, we have those videos for you if you want to start with those less intense techniques. Make sure that if you are doing any technique that is based on assessment, and of course that you're reassessing, ensuring that the technique is effective for the patient that you're working on. And when it comes to all manual techniques, guys, manipulations, maybe more than any other, look for opportunities to get live education. Although I know videos are convenient and I'm happy to have these up for you guys to watch, it would be so much more helpful to use those videos as a recap of one-on-one attention with somebody who's experienced with manipulation techniques. At the very least, grab a colleague, grab a friend, and start practicing these before you bring them into clinic and start using them on patients and clients. I hope you enjoyed this video. If you have any questions, please leave them in the comments box below.